I'm Dr. Marsha Sanity,
And I'm Dr. Caleb Moore,
and this is
the Free Smiles Podcast.
Do you like my outfit today?
I do. I like it a lot. It's what we call a Canadian tuxedo.
My denim?
Yeah. Have you ever heard of you never heard of that?
No.
Oh my gosh. Yeah, it's like a jean outfit.
No, I just think of like
Canadian
Justin
tuxedo.
Timberlake or Britney Spears or
Yeah,
like
they're all called the same thing. Canadian
that
tuxedo.
era of time.
Yeah.
That's what this outfit was inspired by.
It does also embody that, but it's also a Canadian tuxedo.
Okay.
Two things can be true at the same time. Yeah.
Anyway, today we are discussing dental philosophies in terms of conservative dentistry and how we practice.
Yeah, so I think I've always been just mindful of, what treatment planning is for that patient. So when I think about, person sitting in my chair, how that person has lived their life up to that point, Matt, like it impacts what our next steps are going to be. So if
Mhm.
someone comes in, they have a mouthful of cavities, I want to know how we got there. Like
Right.
what's your history? What, even like as far as like how you grew up. So did
Yep.
you always have cavities when you were a kid? Have you been exposed to this bacteria at a really young age? Do we need to talk about diet mitigation? Do we need to talk about, oh, you had a history of having these issues, you've made changes, but now we're just dealing with the effects of that. But really you're kind of at a good place now. We just need to mitigate with some restorative, and then you'll be good moving forward.
Right. And I think that changes over time because your risk at that point in your life when you maybe were exposed to more bacteria or you were in college and your diet wasn't, where it should be, it's different now if you've changed factors, and it's going to be different at every point in life. One thing that comes to mind, Dr. Mack actually shared a video today on Instagram about dentists who watch teeth.
Mhm.
What does that even mean? When you're watching a tooth, do patients even understand what that means? What are we watching?
Yeah. I mean, I think in my practice, I really try not to use the word watch because I
Mhm.
feel like it gives this almost false sense of, oh, this isn't a big deal or nothing's happening. Like, either want to say, this is the issue that I'm looking at right now. We can either treat something now this way, or we can be reactive later and treat
Mhm.
it at that time. So it's more like, do we want to be proactive or reactive?
Yep.
And what that means. That could be, me seeing an initial cavity in a tooth. And again, that goes into, is this person's first cavitation or first incipient lesion?
Right.
Then I'm going to have a different conversation with that patient. I use a few different things to help me determine for that patient. Like I'm using a Cary view, which is a near infrared light that I'm shining on both parts of the tooth. It's giving me an illumination, almost like transillumination, but
Okay.
different. Just a little bit of a different camera that I have. So I'm using that. I'm using the history of their x-rays. But if that same lesion is on a patient who has a cavity every time they come in,
Right.
and I'm seeing that it is through the dentin or really close and they have a really high caries risk, that's when it goes back to that risk assessment. If they're a high caries risk, I'm probably going to treat that sooner than someone in the first situation where they've never had a cavity before. We had this initial lesion. Maybe let's try doing something like Curadont. Maybe let's try
Mhm.
doing a reversible thing first. Maybe let's try mitigating some with some hydroxyapatite or nanohydroxyapatites and just throw everything we have at it. But it's never a one size fits all to me, and I'm never going to say we're watching it. We're going to do something. We're going to do something if
Yes.
that's your home care changing or your diet or something's going to be changing. It's not like we're going to continue on the same way after this point via our conversation or
Yeah.
whatever. What do you think when you think of
I
that?
don't like the term. I agree. Like, I don't like saying to somebody, let's just watch it. When
Mhm.
you come back next time, we'll see if anything's changed. I think one thing that you said, we're going to change something, whether that's diet, whether that's oral hygiene, products they're using, or even introducing new products that could be
Mhm.
beneficial. You should always be changing because there's multiple ways to be proactive about something.
Mhm.
It doesn't always have to include drilling into a tooth. What's funny to me is that when we're in dental school, and I feel like every provider comes out and thinks, we're all individuals, but we come out with this mindset, or we're taught that it has to be like a D1 or D2 or E1. There's all of these characteristics. They say it has to be this before you can drill on a
Mhm.
tooth. However, like you said, it's not a one size fits all. So we have to take into account other considerations before we're just drilling into teeth. I think where it becomes an issue is when a patient, like, Dr. Mack had mentioned, comes to your office and says, well, my dentist has always just said we're watching that tooth, and then it's completely, blown out. It's a huge cavity underneath.
Right.
And then what do you do at that point, right?
Well, yeah, and it is a little bit of trust. So what she brought up in
Hmm.
that conversation was, hey, let's do this one thing. And I do this with patients because I had that same conversation with patients all the time. In that situation, it was a pit and fissure caries.
Yep.
So something that's coming from the top of the tooth into a very deep groove into the tooth.
Hmm.
That is already a non-cleansable area. That is already something that was caused probably by diet. So a lot of those pit and fissure or those top of the tooth lesions are caused by acidity into our diets, sugars, flours and things like that that get easily fermented or fermentable carbohydrates, and they sit into those grooves.
Yep.
So if I'm looking, even that photo, I could see that it looked dark underneath the enamel. There was shadowing happening.
Right.
So if I'm looking at that tooth, I'm not even questioning if that's a cavity or not. That's
Oh,
not even
yeah.
a question on my mind. Like she did rightfully was say, hey, I think we should treat this. I need you to trust me on this situation. And in that case, I'd bring out a couple things. I'd bring out my near infrared light. I would do other things just to like kind of get a different perspective on that tooth. But it really isn't a watchable thing. When a lot of times when we're opening those up, even a slight crack. I haven't seen the word slight because it's just so it's downgrading what's
Right.
happening. Like I had a patient come in. She's never had a crown, really has never had many cavities. I was doing her, initial new patient exam, and I noticed I was on the distal of 15, so an upper left molar, her very back tooth. She does not have her third molar up there. So I noticed, I was like, hey, this like looks like it's, it's maybe a hairline, like almost like a groove in the tooth. But then I
Yep.
took my Explorer and I felt it. I was like, no, this is a crack in the tooth. And I'm like, this is a really, like, it looks deep to me. It wasn't on the x-rays. It wasn't
Hmm.
symptomatic, no biting pain. I was like, I think we should just open this up. I just want to see where this crack goes. It might just be a simple filling or something. Maybe there's just like a hairline part of the tooth. I opened it up. It was literally almost to the point where I had to extract that tooth.
Wow.
That's how deep, like it didn't even show
Hmm.
any darkness on the top of it. It was literally just because I was so dialed in. I had the right lighting and I saw it. And that went so deep below the bone level that I had to do a buildup. I almost had to do like a root canal or extract it if we couldn't crown
Right.
it. Ended up crowning the tooth, and I took photos of it as we were doing it, as I'm excavating. I mean, I was shocked. There's so many moments that I am shocking myself. I'm like, this
Exactly.
didn't look that big, but the more and more we see these things, it's like I wouldn't want that watched in my mouth.
What I loved about what you said in that conversation with the patient, though, was that you gave her options and you were honest with her, because a lot of the times I feel like patients think that we need to have a yes or no cut and dry answer,
Mhm.
and teeth are so dynamic that's not usually the case, right?
Yep.
And so being upfront with the patient, and I even do this a lot with even removing amalgams or large fillings that may be failing over time. I let the patient know what we can do is we can start by getting rid of the bad filling and the
Mhm.
bad tooth and see what's left. The worst case is that we may need to do a crown or
Mhm.
you may need other treatment. But if we're able to get a filling in there, just know that it may not last you as long as other options, right? So the important thing that you did there that I love is giving them ownership over what's happening. What would you like to do here? Okay, this is what you would like to do. These are the risks based on
Mhm.
what I see and what other patients have presented with. So I think that's really important. But just saying, what you could have done in that scenario, you could have been like, hey, I see a small crack. I don't really think it's going anywhere. Let's just watch it next time you come in. And then next thing you know, bites on an almond and that
Mhm.
tooth is split in half.
And then it's split, and then there's no saving it. There's
Exactly.
no, and that's the thing. Like I think we see a lot, and I never say I'm watching a crack.
Hmm.
And I think it's not because of that moment, although that moment I think of often, but it's because I've seen virgin teeth split in half. And I
Hmm.
mean, it's that classic case of a maxillary first premolar. Someone walks in for their hygiene recare appointment, and you're kind of like, they're like, oh, I just want to mention I kind of had some bit on something yesterday. It felt a little funny, but hasn't bothered me since. And I look into their mouth, and the tooth is literally like I can pull the
Yeah.
tooth in half.
Right.
Like it's literally split like a complete root fracture. And I mean, that's an obvious one you can like show a patient, like you separate
Exactly.
it, you take a photo, it's like, okay, this tooth is split. But even like those teeth that people come in, and I have just spent so much more time, I think, on my like limited exams or those types of exams, taking all kinds of angles of photos, because those photos are not only helping me see that better, they're helping my patient understand, like, if there's a big filling in the middle of this tooth, dead set in the middle, no matter how deep it goes or whatever it is, if there's cracks hanging out of each side of that tooth, especially if it's an existing amalgam, that is just asking for catastrophic failure at some
Yep.
point. And that's just how the nature of those fillings were. Like, they were designed to be mechanically retained, so they're not bonded to the tooth. They're not conservative. They had to take away a lot more tooth structure when they removed them. I mean, they still teach amalgam fillings in dental school. It's not like we don't know how they were prepped.
Right.
They're prepped, X amount of millimeters into the dentin because they
Yep.
need to be past the enamel, where now we can keep our preparations a lot more conservative when we're initially treating cavities, which goes back to the whole point of we don't really need to watch things as they used to, because our dental x-rays are way more accurate. I mean, I remember when I first started, I'd had to diagnose and look at x-rays on a little film and hold it up to the light and like, you squint at it, and it's like literally like the size of like a postcard or a
Right.
postage stamp.
Because you're old.
Yeah, because I'm old. And it's like that's how we used to, diagnose things, but now we can take your tooth, we can blow it up to as big as your
Right.
head is, look at things.
And really
We have AI that's integrated into our X-ray systems now. We have all these different technologies. Like, and our preps are so, like, the amount of slot preps that I do,
Oh, same.
tiny. Like, a slot prep, for those who don't know what that is taking, like, you have the crown of the tooth, you take just like the very edge part of that where the enamel is meeting, and you just dissect that one part. You take a very small burr, you're taking a very minimal prep, and that it's not like we're
Yeah.
opening up this giant thing like they used to have to do with amalgam.
So an argument could also be made that watching a lesion like that is negligence, right? There is an argument for that because we now have the technology that we have and the research that we have now to be able to drill out a lesion that's small. We're conserving more tooth structure and extending the life of that tooth. Even though, people consider drilling a negative thing, it's not a negative thing if it's done correctly, conservatively, and we're preventing a future larger, lesion or problem.
Well, let's think about the alternative. Before we had
Yeah.
dental x-rays, even with film x-rays, that was a groundbreaking thing. Obviously, we're trying to decrease radiation now and all that stuff, but having dental x-rays was looking at something at an early state in order to prevent an issue. Like, dental x-rays are there for early detection because we can't see inside of your tooth.
Right.
We don't have x-ray vision yet. I'm waiting for like the radio whatever spider to bite me so I can have some kind of
Glasses or
exactly.
need some X-ray glasses.
Where's the technology of that? But I mean, realistically, we're doing all these things. We're investing in technology. We're investing in education in these things, continuing education, so we can save your tooth. Because the alternative to that previously was wait until it hurts, and then we're going to pull your tooth.
Exactly.
So I think the alternative to, hey, here's a small prep that I'm going to do on your tooth to stop this hole and bacteria byproduct acid from eating away at your tooth, I think that sounds like a better option to me.
Yeah.
Yeah.
I had a patient who came to me and he had some trauma or, a negative experience with a root canal where he wasn't completely numb. So it deterred him from coming back to the dentist for many years. He came in and he was like, at the time, like 5 years ago or whatever it may have been, they had said, I had a small cavity, maybe starting on an upper tooth. It wasn't really bothering me at the time, but over time, I have progressively become symptomatic. Like, it's hurting, it's bothering me now. I can't chew over there. And now I also can't chew on this side because that was the root canal side. And we ended up having to extract that tooth. And it was interesting because they were watching this lesion that was on the buccal surface. It wasn't a cavity. It was external resorption. And so by the time he came to me and I took a CBCT, I had to explain to him, hey, But like you said, the beauty of it was that I had the 3D imaging, so I could show him and explain what was going on. But it was mind-boggling to him because no one had ever. And there's an argument that maybe they just didn't have the imaging or
Mhm.
the understanding. But to tell a patient we're just going to watch the area, and then what does that look like 5 years from now? Now you have external resorption to the point where we're extracting the tooth, and maybe that couldn't have been prevented. But regardless of that, you know, if we have the tools, why aren't we offering it to people, right?
No, and I think that's the truth is I think people that do have the tools and understand how to use them are using them,
Yes.
but I think it's taking time to get there. So I think we see a huge portion of the population, and I started off this way too. Like I started off in a practice. It was me, one doctor, I'm the assistant at that time, one hygienist, and it was four of us. Four of
Hmm.
us that ran this office. We had paper charts. We took regular film X-rays, and that's how he practiced until the day he died.
Right.
And he wasn't old. He actually passed away before his time. Rest in peace, Dr. McLaughlin. Um, but in any case, like that's still happening. We still
Yeah.
have many doctors that's the way they practice for 30 plus years. And, investing in a CBCT, they didn't have them until X amount of years ago. They didn't have
Exactly.
these things. They didn't have scanning. They didn't have all this stuff. And it is a huge burden on the expense of running a practice is having this technology, which, goes to show you that we are expressing a lot of these things into what we want to do. Like we're investing in this stuff, but we also want people to understand that we're not trying to find things. It's not like we're
Right.
like searching, but we're trying to find answers. Like as dentists, as doctors, as scientists in a way, like we're just here to like we're problem solvers.
Hmm.
At heart, we're just trying to find solutions for people and avoid pain. Like we're trying to avoid pain as much as our patients are.
Yeah. And problem solving includes having tough conversations about what was previously done. It's difficult to navigate a conversation with a patient who was seeing this previous provider for 20 plus years, and he was old school in how he practiced, and that's not necessarily a bad thing.
Mhm.
But like you said, if you're not getting better over time and investing in the tools that we now have and having the knowledge, that patient in 20 years may have five teeth that now need crowns, and one possibly is considering, an implant.
Mhm.
And so it's difficult to then have that patient come into your chair and deal with the emotional side of that,
Mhm.
because emotionally they were tied to this provider who they trusted. And so for me, I'm trying to tread carefully in the fact of I don't want to speak on what decisions were made in the past.
Mhm.
However, with what knowledge I have and the experience I have, I would love to share with you what I'm seeing, and if you're open to that.
Yeah.
But it's hard.
And it is hard. Those are hard conversations, and I feel like you never want to you never want to talk ill will about any provider you've ever seen because you don't know the situation. You don't know their education. You don't know um, like how they were as a provider, their philosophy, because things were taught very differently then. Like we didn't have the same materials. We didn't all these things are relatively new, but it's still like having someone come into your chair when you are kind of like the bearer of bad news
Yeah.
in a lot of these situations, especially if they've been seeing someone for X amount of years and they've been told this, and then you look in their mouth and you're like, how do I tell this person that their teeth are like I've had people
Yeah.
come in and even from like overseas where things are done very differently or standards are very different, and you're looking at their root canals, their crown work, and there's like open margins everywhere, and
Hmm.
there's unfinished root canals or these just old materials that are just really just not the standard of care anymore. And maybe if they're not causing that person a problem at the time, then maybe you're like, okay, maybe we will just instead of extracting all your teeth,
Right.
you know what I mean? Like obviously there's a point where you need to kind of take things as they come a little bit instead of doing like a full mouth reconstruction. You have to kind of warm up to that situation or see how that patient feels. But Yeah, you can really go from 0 to 60 really easily with a lot of those situations.
Especially the older materials, and I love that you touched on that because older crowns, almost daily, I
Mhm.
think I'm telling at least one patient that, hey, you have this old crown in here. If you're looking at the bite wing, an X-ray, you can see the margins open. I can feel it.
Mhm.
Does that mean that there is decay extending, you know, to a damaging amount? I don't know, right?
Right.
But what I can tell you is bacteria is leaking through here because it's not sealed. And so it's at a higher risk of needing further treatment. But I feel like patients, if the trust isn't there, then it feels like you're trying to just get them to do a new crown. That's what they think.
Yeah.
Well, this crown's been on here for 10 years. Why do I need a new one? But the reality is we have newer materials that
Mhm.
we can actually watch over time. We can see radiographically what the margins look like
Yeah.
and if that cavity starts to extend towards the nerve. So that's one of the main things that patients should consider more is that if you have a porcelain fused to metal crown or an older zirconia, even zirconia, you can't see through it on an X-ray.
Right.
So it's difficult,
Yeah.
you know.
No, it really it is, and it's tough because I mean zirconia is still a great material that we use a
Agreed.
lot, and I feel like it still is like one of the top materials that we still we will forever use them, and it's changed over time. The
Yes.
old zirconia is not the same as this the
Yep.
current zirconia, but that's the difference. The caveat between the two is if I'm using an Emax crown, I can see between those margins, but is the likelihood of possible failure or fracture in that
Right.
higher? It is. It always will be. There's no doubt in my mind that, or doubt in the science or the whatever that you can have, you
Like
know,
flexural strength,
flexural
fracture
strength, things like
toughness.
that. And depends on the patient's situation.
Right.
That patient's bite
Yep.
is huge. And there's pros and cons there. So it's like I think when you're talking to a patient, it's like no matter what, if there's an open margin, if something is open, then there's never gonna be like that's never ideal. There's
It's
always
not
gonna
going to be
be
Yeah,
yeah,
it's not going to be better in 6 months if we watch it, for
yeah,
the next 6 months or a year. If
right,
anything, more bacteria is going to leak into that over time.
yeah,
But at least it's our responsibility to have those conversations
mhm,
because it's risk assessment no matter what, whether it's determining are you more at risk for a fracture if we choose the Emax, or should we go with the Emax because your occlusion is more aligned
right,
and you're a higher caries risk because you get
yeah.
cavities more
So maybe we
often.
can check exactly, and that's exactly what the conversation is. I mean, I'm like, I swear I'm still shocked. Like when I'm taking off like a crown that I know has decay, but to the extent, like sometimes I'm like, oh, like from the it's just on the buckle, like
Yep.
that's a really easily cleanable area, but I'm noticing that the margin's now open, it's looking dark, it's looking sticky. Let's take this PFM off. I just did this the other day and I was like, I was shocked. I was shocked at the amount of decay that was underneath this crown because, on the imaging, like what I'm showing the patient, this is why I'm recommending this to be done. Um, he agreed to get it done. He got it done within like the week. It's not like he was
Yeah.
like hesitant on doing it by any means. But when I showed him, I was just like, in the back of my mind, I was like, yeah, like we can just do it, but let's
Whenever
get it
you're
done.
ready. Like it didn't
Yeah.
seem like it was.
But in my
Yeah.
mind, I was like, "Oh my gosh, I'm glad we did this like in a couple weeks after we
Hmm.
talking about it." And that like brings me back to that conversation of like I'm even forever changing and evolving how I say things or how I view things because I can see how south things can go, even in
Exactly.
someone who has great hygiene and things like you physically can't clean underneath those margins
Yep.
once they're open. So yeah.
That happened to me today, actually. I was replacing two amalgam fillings.
Mhm.
Um, One ended up being a crown because of the size and structural support that it needed. The other was just a filling. I shouldn't say just, it's
Mhm.
not just a filling. But my assistant actually made a comment, and I was thinking it, and I was almost glad that she said it because it reinforced the treatment. Not that we need to by
Yeah.
any means, but she was like, "Man, I'm glad we did this today." And
Mhm.
I was almost taken back because I was like, yeah, I am glad we did this today because
Right.
once we got that metal out of there, I mean, it was all soft and it was large, but you can't see that on the surface.
You
It's
can't
like,
see it on the
oh,
surface, and there's only like amalgam fillings are one of those things. I mean, there's a lot of controversy, and there's a lot of reasons why people want them out of their mouth, but there's also a lot of reasons why we recommend to have them out when we're starting to see even the start of failure of that filling, because it can go south so quickly. Like there's, I think every single time I'm taking out one of those old amalgams that I was like, oh yeah, it's like starting to break. We should, if someone is a proactive person, which a lot of our patients are, in that way, but even when they're proactive and we're all on board, again, I'm still like, oh my gosh,
Yeah.
I'm glad we did this, because this could have been literally a catastrophic event, and we would have lost this tooth. Like this would have fractured, this decay would have kept going deeper. We could have had all these issues. And to me, it's really just about being as conservative as possible. Because to me, being conservative is you not losing that tooth. Like that is the most conservative that we can be, is keeping that tooth in your mouth for hopefully your lifetime.
Yeah.
And
so I think the takeaway is that watching a tooth doesn't necessarily mean that you're a conservative dentist. Yeah. And if a provider is telling you they're watching a tooth, it doesn't necessarily mean that provider is wrong. We're not saying that, but maybe inquire more about what you're watching and what's happening.
Yeah. And what can we do to maybe change the outcome of the situation?
Yeah.
Because once something starts, it's not like it's going to not be there. It's just either going to be halted at a certain part of that disease process, but it can still continue even with that kind of intervention or those changes, depending on where that is.
Yeah. And just be empowered to ask, what can we do? Mm-hmm. What are the options? What are the risks, benefits? And, how can we make sure that this isn't going to be a bigger problem for me if it is watched? Because at the end of the day, whether you are proactive or reactive, at some point it's going to need treatment. It's just, what do you want to invest in? More proactive treatment or the reactive?
Yep. Thank you so much for listening. If you enjoyed this episode, please share it with a friend. Don't forget to leave us a comment, rate us, and subscribe so you never miss an episode. We appreciate your support and look forward to bringing you more great content.